Yeah, good. Speak with you. Okay. All right. Let's get started. Okay. All right. My name is Nasibu Mwande, the Vice Chairman for TUHEDA, Tanzania UK Healthcare Diaspora Association. And today we have a very international panel sharing different experience on COVID. So I will let Dr. Gideon introduce our panel today. Karibu Daktari.
Thank you very much. In today's talk about COVID-19 and international experience, we are lucky and very grateful to have a panel of 3 people from Middle East, Dubai, from Gibraltar, and from Malawi. And before starting this, I think I want to say to everyone that for the country of Tanzania, we are mourning the death of our president, and therefore it's a sad moment for all Tanzanians, and it's a big loss for Tanzania, but also a big loss for Africa. And to start with, I'm going to invite Dr. Khadija Hafid. She's a colleague of mine, but also she's a consultant physician in diabetes and endocrine in Dubai, in Rashidi Hospital. She is associate professor in internal medicine. She's also the editor of Dubai Diabetes Journal. Welcome, Dr. Khadija Hafid.
Thank you so much, Gideon, for that kind introduction. I'm delighted to be joining you, dear colleagues, friends, family. I can see so many familiar faces. So let me start off by sharing the screen. And so can you see my slides? That's usually the opening question. And then let me put that in PowerPoint. Right, so once again, I'm really delighted to be joining you in this webinar. And I'd like really to thank the organizers at TUHEDA for inviting me to give this talk today. And what I'd like to do is share some of my experiences with the COVID pandemic in the United Arab Emirates. As you know, the United Arab Emirates is my adopted home, but my heart is always in Tanzania. More so now as we mourn the loss of our great leaders in just the span of a few weeks. And I pray that we can all heal and move forward with stronger unity. So these are my disclosures. And I think you'll all agree that with the COVID pandemic, what we saw in parallel was an infodemic. And I don't know about you, but I found it very difficult and challenging to navigate through the barrage of information that was coming through constantly. And therefore, it really is a moving target because we've had to adapt to guidelines, protocols, evolving practice even. And suffice to say that we need, as clinician scientists, researchers, to try and stick to what is evidence-based and avoid pseudoscience at all costs. So what I'm going to tell you today, or what I might say today in COVID times, may not actually hold water tomorrow. So what I'm going to try and do is stick to what we do know so far. And I'll take you back to how it all began. So this is the coronavirus timeline. And as everybody will remember, December 8th, 2019, the first patient developed symptoms of the then called Wuhan coronavirus. And then it wasn't until the end of December when China actually alerted the WHO about several cases of pneumonia. And if you remember, there was a paper that was also published in the New England Journal of Medicine. Then on New Year, the Wuhan wholesale seafood market was shut down because they thought that this might be the cause and the source for the outbreak. A week later, the Chinese were able to identify that this was a coronavirus. And then their first death was recorded on January 11th. By January 13, the virus had already moved out of Chinese borders, and the first case was reported in Thailand. And by January 29th, the death toll had almost exceeded more than 130,000. Moving along, on January 30th, the WHO declared that this was a public health emergency of international concern. A month later, they moved the assessment from high to very high risk. And then they dropped the bomb on us on March 11th and said, this is a pandemic. What about us in the UAE? We had some notable milestones as well. So January 23rd is when we had our first 4 cases of confirmed coronavirus. And this was a family from, yes, you guessed it, Wuhan. They were here in Dubai for celebration of the Chinese New Year. And it was the grandmother who presented with flu-like symptoms. February 28th, another event took place that was notable and the public woke up. So this was when 2 cyclists from the Italian team tested positive for COVID-19, and the UAE cycling tour had to be cancelled. The ministry then ordered that all the people who were staying at those 2 hotels where the cycling teams were staying had to be tested. And then 2 people who had come in contact with the cyclists were also quarantined. On the 3rd of March, the authorities announced that all schools and universities were going to shut down for a period of 4 weeks. And we were informed that spring break has been moved forward. Well, it was the longest spring break our kids ever had, because that moved on to summer as well. And then on 25th of March, our favorite carrier, Emirates Airline, suspended passenger flights, and they were only running repatriation flights to select destinations. So we had a lot of people who were stranded. And April 4th is when we went into lockdown. Initially, we were told it's going to be only for 2 weeks, but it lasted 3 months. It's a notable date because it was also my son's 18th birthday. And so he celebrated his 18th birthday in lockdown. Lockdown is not a new concept, by the way. We learn from prophetic traditions that the Prophet, peace be upon him, had actually advised people when you're when there's an outbreak or a plague in a land, do not enter it. And if a plague breaks out in a place where you're at, you do not leave that place. But it was actually the Persian scholar of medicine, Ibn Sina, better known as Avicenna in the West, who actually came up with the concept of isolating patients to prevent the spread of disease. And he had suspected that microorganisms could be the cause for spreading diseases. And therefore, he thought if you could isolate patients, you would be able to spread this human-to-human contamination. And he came up with the idea of isolating people for 40 days, and he called that method the Arba'iniya. And this you can read about this, it's very interesting, in the Canon of Medicine, which was published in 1025. Quarantine. What are the origins of quarantine? Well, in the 14th century, the merchants of Venice adopted Ibn Sina's concept. And they did that in an effort to protect their coastal cities from plague epidemics, because in those days, they used to have a lot of outbreaks. So they put out an order that all ships that were arriving in Venice from infected ports were required to sit and anchor for 40 days before they could come into land. And the word quarantine originates from 40 giorni, which in the Venetian language was 40 days. So this is beautiful Dubai with a beautiful skyline at the height of lockdown, and you cannot see a single person on that beautiful beach. So where is Dubai? It's part of the United Arab Emirates in the Persian Gulf, bordered by Saudi Arabia, Bahrain, Kuwait, Oman, and Qatar. We are a small desert nation that is comprised of 7 emirates, Abu Dhabi being the capital, Dubai, the business hub, made famous for, of course, many things, amongst them the Burj Khalifa, the tallest tower in the world for now. And then we have Sharjah, Ajman, Al Quwain, Ras Al Khaimah, and Fujairah. We have a unique situation in terms of our population dynamics, where 90% is an expatriate population. So the natives, the Emiratis, are really the minority. So the population is largely, it's more densely populated in Abu Dhabi, the capital, and in Dubai with almost equal proportions. We're close to around 10 million nationwide. And because of the geographic proximity and historical ties, most of the people in the UAE come from the Indian subcontinent, Pakistan and Bangladesh and Nepal, and then you have people from Philippines as well. Egypt and the other neighboring Arab countries, Westerners and Africans are quite a minority. So this is the current status as of today. This is the latest updates that we have in the United Arab Emirates. Since the start of the pandemic, we've recorded a total of 1,438 deaths. And there have been 5 new deaths that's been recorded today. So I don't want to turn this into a virology lecture. That's not my aim. But this is what the coronavirus looks like. And it's these spike proteins that actually allow it to gain entry into the human host by anchoring onto these ACE2 receptors. Now, what about the transmission? It's thought that the source is probably a bat, and then there's an intermediate host that could probably be the pangolins, snakes, mammals. It's not really decided yet. We think probably the pangolin. There was then this animal to human transmission, and then finally got onto the host where then you could have the human to human transmission. And because of this global world that we live in now, where travel is so easy, it was so easy to spread the virus. So we've lived with the coronavirus for millennia. And in fact, we've had similar outbreaks, but they were more contained. A few years ago, we had the MERS-CoV, that was the Middle East respiratory virus. And we knew then that the intermediate host was most likely the camel. A decade ago, there was also the first SARS-CoV, which happened mainly in Singapore and Taiwan. And at that time, they could identify that the intermediate host was the civet cat. For this pandemic, we think that it's probably the pangolin, but we're still not sure about that. So, coming to symptoms then. Fever, cough, shortness of breath, by far the commonest symptoms that patients present with. Flu-like symptoms, but this is not an ordinary flu. And the WHO put up this infographic to inform people about the most common symptoms, but as you can see, it can affect other organ symptoms as well. And I like this cartoon that was published by Dr. Gupta in Nature Medicine that really illustrated that this is a multi-system disorder. And for some of you who are dealing with patients in the hospitals on a day-to-day basis, you will have come across some, if not all, of the complications that are shown here. What about the natural history? So we know that there's a pre-symptomatic phase, then there's a virological phase, and then you get the immunopathological phase. So from exposure to getting the infection, from 0 to 3 days, you may not have any symptoms at all, and were probably considered non-infectious at that point. from day 3, although you may have symptoms, we think that patients are already infectious by that time. And we know that 40% of patients develop no symptoms during the course of their illness. The virological phase usually, we think, starts at around day 5, and it may present with fever, cough, fatigue, loss of taste, loss of smell. There may be GI symptoms as well. At that point, the victim is now infectious, but the infectivity rate is waning down. By the second week, for some people, they may then develop the respiratory distress and pneumonia, requiring either hospitalization, ICU admission with mechanical ventilation, and so on. And we think that they may still be infective up to 20 days. So what about in terms of treatment? So we think that with using the vaccines, we can at least stop people from getting infected. So that's one way of, tackling this in terms of the prevention. Antivirals, we've had a few, some promises, but we really can't say that we've got an effective antiviral agent as yet that can stop viral replication during the early phase. And then you've got the pulmonary and sort of the systemic phase, whereby now the host sets about all this inflammatory response reaction. And at that point, then we have the anti-inflammatory agents. Corticosteroids, as we've seen, are the only sort of agents that work, interleukin-6 inhibitors, and some of the things that is now slowly emerging. So who's at risk of getting severe COVID? We know that adults of any age are at increased risk of severe illness, but there are certain groups of people who are more likely to get a severe form of the disease if they were to contract the virus. And that includes people who've got certain malignancies, so they've got neoplastic disorders, chronic kidney disease, chronic obstructive pulmonary diseases, heart conditions, heart failure, coronary artery disease, obesity, pregnancy, sickle cell disease. The list is not exhaustive. There are more conditions, but I've just sort of highlighted some of the more common ones. And diabetes. Diabetes is really important because the first paper that really sounded the alarm bells was the paper from China, where their CDC reported that the case fatality rate for people with comorbidities was much higher than for those individuals who had no comorbidities. And as you can see there, for those who had cardiovascular disease, it was around 10.5. And for diabetes, it was in the order of 7.3. So we have a collision of pandemics, and there's a very intricate interplay between diabetes and COVID-19. And I picked diabetes because I'm passionate about the disease. It is what I do on a day-to-day basis. I'm a diabetologist by training. Why is that important? Because the prevalence of diabetes is increasing worldwide. In the Middle East, we have the biggest problem. The United Emirates, in fact, features in the top 10 countries with the highest prevalence of diabetes. And if we look at the trajectory for all the continents, you can see that the highest increase is actually going to be in Middle East and North Africa and on the African continent. So we have another sort of, this is an epidemic that's there, and it's just going to get bigger if we don't do something about it. So for the first time, we have a non-communicable disease that's actually killing people as much more, I would say, than a communicable disease. And here are the figures where over 1 million people dying in 2019, according to the International Diabetes Federation, when compared to people dying of HIV and malaria. That's not to take away the importance of HIV and malaria, but just to highlight that this non-communicable disease is something that we need to pay attention to. So moving on, we've seen data again from other places in the world, whereby they've also looked at their patient profile, and they've also reported that the mortality rate was much higher in those with diabetes compared to those without. the UK did this wonderful study. It was a whole population study. And the authors also reported that for those patients with type 2 diabetes, and what was most striking, because we didn't think, we thought maybe type 1 would be spared of it, but even patients with type 1 diabetes have a much higher rate of mortality when they contract the disease as compared to those patients without any diabetes. We did our own study as well and looked at our own patient population, and we found the same thing, that diabetes is really a strong risk factor for the development of a severe form of COVID infection. So what are some of the potential mechanisms? And listed here are some of the things that the host characteristics develop. And when you get the infection, you have this inflammatory sort of cytokine response, TNF interference response as well, which may lead to the lung fibrosis and ultimately acute lung damage and development of the acute respiratory distress syndrome that we see in our patients. And then there may be release of reactive oxygen species and interleukin-6, which is thought perhaps to cause hyperglycemia. And that can then lead to cardiovascular and thromboembolic events. Activation of the renin-angiotensin system can also lead to insulin resistance and vascular damage. And then with the increase in the D-dimer and fibrinogen products, you get an increase in blood clots, and all that put together can increase both the cardiovascular and all-cause mortality. On the other hand, we have obesity as well as a risk factor for severe COVID infection. And this was an elegant paper that was put forth in circulation by John McMurray and Naveed Sattar. And they sort of put out what could be the plausible mechanisms that could make obesity a risk factor for severe COVID-19 infection. And again, you can see that the most important things are this dysregulated hyperimmune response. We think that with obesity, you get a dysfunctional immune response. There's also the problem with lung dynamics. So people who have obesity have usually lower FEV1 and lower FVC, and they may have their diaphragmatic contractility might also be impaired. People with obesity have also higher risk of having diabetes, thrombotic potential, high blood pressure, and cardiac and renal problems, and therefore that then adds on to their risk of having more severe infection and poorer outcomes if they get the infection. Furthermore, we know that the lungs in people with diabetes also have certain characteristics that make them more vulnerable to pneumonias. And that's why we always offer the flu vaccine and pneumonia vaccines we encourage our patients with diabetes to take them. The reason for that as well is we know that they've got this reduced lung dynamic compliance. They may be lung autonomic neuropathy as well, with reduced mucociliary clearance, a reduction in the respiratory muscle strength as well, and muscle dysfunction, which can then predispose them to having more severe forms of infection. Moving on to how we manage the pandemic. So what are some of the things that we did here that really worked? So when I reflect, early surveillance, access to screening, tests, and contact tracing was extremely important. We had a command center and we had an integrated pathway, and I'm sure our next speaker is going to talk a lot about her experience in Gibraltar. Social distancing, it was painful, but it was necessary. The mask mandate, it was reinforced, and we were handed heavy penalties if we didn't comply to it. And I think for us that worked. Quarantine facilities, we had to quickly convert facilities into field hospitals, and even five-star hotels at some point were used as isolation facilities. Finally, vaccination, when it came, we're trying to make sure that everybody has access to the vaccination. But the most important thing, I think, is mitigating misinformation. And I like this infographic that is there on the WHO website. And they talk about how we can actually mitigate spreading false information and misinforming the public. And this particularly happens in our WhatsApp groups, they're important because they inform us of important social events. But it's important that when somebody shares a piece of information, think about, is that true? Is it come from trusted resources? Have you double checked about the facts before you actually share it with the group, in order that we're just sharing information that's actually accurate and can help people? So, flattening the curve, we know that without any preventive measures, we would have remained with a high number of cases, and that would have overwhelmed our healthcare capacity. So, simple things: washing hands, wearing the mask, the social distancing, and then when you have access to the vaccines, making sure that you go ahead and get vaccinated. So in Dubai, we were fortunate in that we were able to have these drive-through testing centers. And then our convention center was turned into a field hospital. And here was in the first wave in July of last year, when we thought we had overcome the virus. We have the last patient before they had actually closed down the field hospital. This was the last one being given a very sort of befitting farewell with flowers and everything, because he was the last patient that was being discharged out of the field hospital. Moving on now to vaccination, and we've had inspiration from our leaders. This is His Highness Sheikh Mohammed bin Rashid Al Maktoum. He's the Prime Minister of the United Arab Emirates and the ruler of Dubai. And shown here, taking his jab and encouraging the rest of the public to follow through as well. And here's my son. He was able to take his jab just a week ago. And the minute he put that on his Instagram page, all his friends signed up to take the vaccine as well. So this is our vaccination update as of today. And we've had around 73 doses per 100 people. So how are we doing compared to the rest of the world? And I'm happy to say that we are in the top 10 nations of doses per 100 people. Israel is on the top, followed by the United Arab Emirates. I was very impressed to see that Seychelles is also there, followed by the UK, the US, and Bahrain. But in terms of total vaccinations, the US first surpasses everybody, followed by China, and then the UK, and we come down, but we're still on that list. So what about the vaccines that are accessible to us? We have the AstraZeneca one, we have the Pfizer, we have the Russian, the Sputnik 5, and we have the Sinopharm. And as you can see there, these are of different types. The AstraZeneca is a viral vector, and just like the Russian Sputnik 5, whereas the Sinopharm is an inactivated virus, and the Pfizer BioNTech is a messenger RNA. All these so far need to be given in 2 doses. So the most frequent question I get asked by my patients is, doctor, which one should I take? At a personal level, in our family, we've had a taste of each one of those. Myself and my kids have had the Pfizer one because that was what was offered at the Dubai Health Authority facilities. My husband took the AstraZeneca one because when he went for his appointment, that was what was available. And my parents have taken the Sinopharm one. So going down to therapeutics, lots of promises. We know from the recovery corticosteroids work, and therefore we're using that quite extensively. The IL-6 inhibitors, tocilizumab, we have access to as well. The monoclonal antibodies, a lot of promise for the pre-viral replication stage to try and reduce viral replication, but we don't have access to that as of yet. And anticoagulation for hospitalized patients is in use quite extensively. So if I look at the challenges moving forward, we've had to face a lot of grieving. As a healthcare provider, we're no strangers to death, but there was too much death occurring too often. And therefore, there's loss of lives and loss of livelihoods. There's an exhausted healthcare workforce. And therefore, we were urging the public to do all the things that we know can try and reduce the transmission of the virus so that healthcare providers could also take a breather. Missed training opportunities. Medical students and residents got affected as well because medical students were not allowed to come into the wards because we had converted the hospital almost at one point to just COVID cases. The digital divide, access to telemedicine. Although we have excellent internet connections all over the country, it's not everybody who's able to download the app to have access to their doctor on a camera. Coordination across different sectors. So it was important for us to coordinate between the community services and the hospital services so that the hospitals are not overwhelmed. And then this is something that is, of course, every country on the globe is suffering from, is the economy and billions of unforeseen expenditure. Then there's the great unknowns. We're not sure about the duration of the protective immunity from the vaccines. We're still not sure about the vaccine dosing frequency. Is it going to be like the flu jab that you have to take once a year? Is it going to be certain populations that need to take it? We still don't know. What about efficacy of the vaccine on the new virus variants? And then what about antiviral treatments and the concept of long COVID? We're now seeing a lot of that in the outpatient clinics where now patients are coming in, they've cleared the infection, but they're still very symptomatic. Before I end, I'd like to pay tribute to all healthcare providers across the globe. But I'd like to have a special shout out to a special group, a unique group of individuals. And these are nurses, nurses on my unit, nurses in your hospitals, nurses all over. And although we're still battling this monster, we have to embrace the fact that until all are safe, no one is actually safe. And with that, I'd like to thank you for your attention, and I look forward to taking your questions later on. Thank you very much.
Right. Thank you very much, Dr. Hafid. That was a fantastic presentation, and thank you very much for sharing your experience. So I think you can prepare your questions for later for Q&A session at the end of the presentations. But for the moment, I will welcome Dr. Fatma Mansab to carry on with the presentation. Dr.
Thank you. I believe that you will be navigating my presentation on your end.
Okay, let me get it started. I think I think I hit a snag as well. I think somehow, wait a minute.
That's fine. I mean, I think just to start things off as we try to navigate my presentation, I would echo Dr. Khadija's, last slide about this being a global problem. And I think it's very important that when you look at COVID-19 and the response that every country gives, you have to see it as a global problem. So whilst you're sorting out your locality and you're trying to put in best measures for your particular locality, I think it's important to know that nobody's safe when everybody isn't.
Okay, I think sorry. I think Gideon might have to share them because I think I'm hit a snag with my MacBook won't play.
It might be a Mac thing, actually, I should say.
It might be a Mac thing. I think you have some problem because there's a MacBook. Gideon, would you please rescue us? Yeah.
So I'll talk a little bit about where I am. I'm talking from Gibraltar. Gibraltar is a UK overseas territory with a population of around 43,000. And the statistics today is we have 25 active COVID-19 patients in the community, and we don't have anybody hospitalized, 0 patients in hospital. So that has been quite a success, but we have gone through 2 surges. Back in March, 3rd of March to be precise, we had our first patient in Gibraltar, and this was a couple from Italy. And the response in Gibraltar has been a proactive one. So Public Health Gibraltar responded along with the government very swiftly and very quickly. So within less than 2 weeks, we were able to lock down all persons above the age of 70. At that point, it had been seen that this was a risk factor, age was a risk factor. And so we decided that this would be a good start. Very, very quickly after that, there was a population lockdown. And because of that, the numbers in Gibraltar remained low. Most of the cases were community cases. And there was a low threshold for clinical assessment. And I think our second surge, which we saw in January this year, was the more significant one, where we had, on a bad day, an average of 118 patients as a 7-day average. So we're doing quite well. I think a combination of social restrictions when numbers were high, a combination of government being proactive and supportive of both businesses as well as healthcare workers. I think the fact that the public was compliant, all these allowed Gibraltar to maintain lower cases than other places in the world. And the more recent success with Gibraltar has been the vaccination program. So currently 90% of the Gibraltar population has had their first dose. And in fact, over 60% have had their second dose. So in terms of viral sort of transmission interruption via vaccination, alongside public health measures, Gibraltar is doing relatively well. And I think we rank quite highly on the vaccination sort of access. I believe as of yesterday, Gibraltar was one of the highest to vaccinate their population. So one of the first things we looked at in, sort of as a response, COVID-19 response in Gibraltar, was what would be the best way to, sorry, I'm hoping that my presentation would come on at the moment. You'd like me to carry on?
Yeah, you carry on. I think it won't load up, so we try to find some other way.
Okay, that's fine.
Yeah.
No, that's fine. So one of the, what do we know? One of the first questions I'm sure with every other healthcare system was, what do we know about COVID-19? How can we use that information to make the response in Gibraltar sound, safe? And one of the things we all know is the majority of patients are mild. I think, about 80% are known to have a mild cough and, cold-like symptoms. Some of the infections are more life-threatening, and within the 20%, we have people who will progress to severe systemic inflammatory response syndrome. And of course, multi-organ manifestations that Dr. Khadija spoke about. So obviously this, cohort of progressive COVID-19 are the ones that we look out for. Now, the risk factors, again, just to echo, our age, we know that older age is a risk factor. We know chronic disease. We talked about, I think Dr. Khadija talked about diabetes, but obviously, high blood pressure, heart disease, liver disease, all these things contribute to COVID-19 severity. And of course, we know that ethnicity also contributes as a risk factor. So people of BAME, Black and Asian ethnic minority are 4 times more likely to be hospitalized, and this leads to higher mortality in this group. I do think that we also have to think about leadership and government engagement as a risk factor, because I think governments who have listened to science, those who have worked alongside healthcare workers and public health, have done incredibly well in their response to COVID-19. Now, I had a table that sort of showed you the risk factors of both hospitalization and the need for sort of ICU intervention. What we do know, oh, sorry, there's an echo.
Yeah, continue. Go ahead.
Should I go? Right. So.
Oh, there you go.
Hello, there we are. Thank you. So I think we talked about, Gibraltar's peak that was seen on the 6th of January, where we had 172 cases. Thank you, Dr. Gideon. And we talked about the vaccination program in Gibraltar, and we know that 90% of the population has been vaccinated with their first dose, and over 60% with their second. And if we move on to the next slide, we will see that just topping up Dr. Khadija's slides there, that Gibraltar is currently doing really well. But per 100 people in the population, I think we're sort of higher than Israel, who are, they were the pioneers of the vaccination program. Now, if we move on to the next slide, I talked a little bit about, what we know about COVID-19, and we know that majority of people are mild, and they sort of recover within the community. And there's those who go on to form the more progressive COVID-19. And we know that there's risk factors, associated with severity in COVID-19. And on the next slide, there we talk a little about the sort of risks associated, for instance, with age. So if we take people of between the ages of 20 to 29 as our reference group, we can see as the older age groups, the risk of hospitalization increases. So people over the age of 85 are 13 times more likely to be hospitalized compared to the reference group of people of 20 to 29. And on the next table, what we're seeing is the comorbidity. If you go back, what we see there is the percentage increase in death. So this was a cohort of over 20,000 people, and they looked at different comorbidities and their risk factor and how they affect mortality. And you can see, obesity, for instance, is 33% higher. Dementia, one that isn't talked about enough, you can see it's 40%. So these are very real risks that contribute to not only severity of COVID-19, but also mortality of COVID-19. Next slide, please. Now, what we also know about COVID is immunity. So there was a lot of discussion about waning immunity in COVID-19, which is unusual because, you know, normally when you and I get a cold, we develop immunity for that particular cold and we don't worry about it. But there was obviously a lot of chatter because patients were found to have lower titers or none at all after some time. However, a China cohort, and we looked to China because they have the oldest cohorts, and 8 months on from the first case of COVID and of inpatients, they still track immunity. So we can sort of relax a little bit and know sort of this is not a complete loss. People who've had COVID-19 do have some immunity to it. And vaccination. So this is obviously an effective way of interrupting viral transmission. And as we saw on Dr. Khadija's slide, the spike protein being the sort of access point to cells and the virus. And, you know, alongside public health measures, vaccination is extremely important. And the emergence of new variants has been a challenge. I think nobody expected the new variants to arrive so well. It's nothing new. What we do know is, you know, new mutations in viruses do occur. With, you know, SARS-CoV-2, this has happened relatively fast. And some of the good news is the studies that they've used to look at protection against new variants with the vaccines that we currently have, you know, they've already shown that there is some protection. But what this means, perhaps like the flu, we may have to have booster vaccines on a sort of yearly basis and so forth. So what are we talking about here? COVID-19 response, the most important things in our view, we think, is early intervention. And the other important one is monitoring and triaging care pathways. And why do we think these things are important? Because what we do know is the outcome is that you do reduce the disease severity, you do reduce the length of hospital stay, you reduce the need for ICU, and this allows healthcare capacity for other life-threatening illness, such as cancers and chronic illness. If we go in the next slide. Now, I'd like to draw your attention to this. This is a study from China. Again, we draw on China because, as we know, they are our sort of origin, and we have the oldest patients. And what we're looking at here, when we're talking about early intervention, is we're looking at onset of symptoms versus admission in hospital. And what they found, if you look at graph A, each circle represents a particular cohort in China, and they've each reported their onset of symptoms versus when these people were admitted. And on the x-axis, you can see that people that were admitted early, if you look at between 0 and 3 days, have had less likely to be seen to need ICU intervention. As you go up the time to admission, and this shows up to 11 days, you can see that it shows that there's a more chance, over 40% of those that needed ICU intervention. And if you look at graph B, this is related to mortality rate, which follows the same trend. So those who are admitted early are less likely to die, essentially, compared to those who were sitting with COVID symptoms without admission. Next slide. So early identification of progressive COVID-19 is very important, particularly in the community where we're asking people to stay at home. Because what we do want to know is that those who are unwell have access to clinical input. So once people are identified early, it means that treatment can be implemented early. And the outcomes for this have been shown. If you catch these people early enough, you reduce their severity to, severe COVID-19, you reduce the rate of mortality in this group, and you reduce the length of hospital these people have to stay. So for those who are hospitalized but caught early, they're less likely to need sort of ICU intervention and such like. And again, if we come back to management of chronic disease, it's important that those who have, cancer, diabetes, heart disease and so forth have access to healthcare. Because while we leave these people behind, what we're doing is we are creating a problem with management of disease that can be life-threatening. Next slide, please. Now, one of the things that we found to be quite concerning was the correction of oxygen, particularly the implications on mortality. So people with COVID-19 pneumonia potentially were staying at home and, essentially hypoxic. They were functioning with oxygen levels below 95%, and the normal range for oxygen saturation is between 94 to 98%, ideally 97.5%. And what we do know that delayed correction of hypoxia, which is oxygen levels under 95%, is shown to have progression of severe pneumonia. We know that this increases the chances of mechanical ventilation, and also we know that this increases mortality. So this forms as part of the early intervention strategy, where if people have access to clinical input, they're more likely to be caught early and therefore not be hypoxic in the community without detection. Next slide, please. And Dr. Hadija talked a little bit about immunosuppressive drugs that are widely used. So dexamethasone is used in the recovery trial here in the UK. And we know that they've done a sort of randomized clinical trial between COVID patients who receive normal care and those who receive dexamethasone as part of their treatment. And what they found that, within the 20-day mortality rate, those who were receiving invasive mechanical ventilation did better, and those receiving oxygen did better on dexamethasone compared to COVID-19 patients who were receiving normal care. These patients also had shorter hospitalization compared to the usual care group, and were more likely to leave the hospital alive after 28 days. So again, this supports the notion where you get treatment early within patients, you're more likely to affect the trajectory of the disease, and therefore you're more likely to save lives. Next slide, please. Now, what we looked at, so as part of the response, COVID-19 response, what we were interested in is how are other countries triaging their patients? So once you had a confirmed COVID-19 patient, what was the plan? What are other people in the world doing, and how can we adapt this as best practice for COVID-19? And what we did is we did a simulation study where we had a group that were mild, those who were moderate, and those who were severe COVID-19. And we subjected these groups to each online symptom checker to see what would be the advice that was given in different nations. And we had COVID-19 mimickers within the mix. So we had sepsis, we had, secondary bacterial infection. These are time critical, illness that need to be seen, and intervention is needed. Now, what we found was quite startling, actually. What we found was that different nations responded differently. Now, if we look at Singapore, who we all know is doing very well, 88% of the patients that we input in the government online symptom checker were referred on to clinical assessment. They had a low threshold for clinical assessment, and they took into consideration age as a risk factor. So if you were over 65, you were automatically triaged to see a clinician. If you had a comorbidity, you were automatically triaged to see a clinician. And if you are young, which would be considered low risk, if your symptoms hadn't resolved within 3 days, you were referred to clinical assessment. Japan had a similar robust onward sort of referral as well, where you had clinical assessment in 77% of the simulated cases. And what's interesting is the UK and the US had quite a high threshold for clinical input. Now, 44% of cases, this included people with supposedly severe COVID, those who may have had sepsis and secondary bacterial infection that were being triaged at home. And one of the concerns that we had was that we were expecting patients to be doctors at home. So we had an online platform which would ask questions. So one of the more concerning questions that they had was, are you short of breath, for instance? And whilst in Singapore and Japan, if you ticked yes to shortness of breath, you were referred on to clinical input. In the UK, you are asked, do you think you're doing better? You can carry on your normal, chores and such like. And if you said yes to that, you are asked to stay at home. And, I don't think a clinician would feel comfortable themselves to tell someone like that to stay at home. You'd certainly want to know their vitals at the very least. So what we were saying, the patient-led assessment tools really potentially worsen the outcomes of COVID-19. And what we need to use these tools for is more to catch those who wouldn't otherwise be caught. So if we're using these tools as a safety net, for instance, they're actually a very effective way of triaging COVID-19 patients, because what we've done now, we have a low threshold for clinical assessment. At the same time, we're using online tools to catch those that we wouldn't. Next slide, please. Which brings me to monitoring COVID-19 patients in the community. I think that we would agree that, if we have a robust clinical pathway for COVID-19 patients, that, we avoid delaying presentations of COVID-19, because we know that that leads to a higher mortality rate. And in fact, it leads to more healthcare resources being used. So if we have a patient who's seen early, intervention is introduced early, they're less likely to need critical care. So we've actually saved on resources as opposed to those who go in and on admission after 1 day, they move on to ICU. So, these are the sort of things that, we have to sort of look out for. Early identification, as we know, as I say, the pressures of healthcare services will be reduced if this was implemented. And I think actually easing of social restrictions. So, if we're seeing people early, we're discharging them early, they're less severe, the healthcare is not overwhelmed, we're more likely then to relax the rules. It has a knock-on effect on how this sort of, pans out in the community. So, I think that the message is to have a low threshold for a clinical assessment for people with COVID-19 in the community. Next slide, please. So if we're assuming that early intervention, saves lives and resources, what we want is COVID-19 patients have access to clinical care, clinical assessment early on in the disease. What we want is once we have everyone assessed, up until symptom resolution, these people remain on some sort of follow-up sort of triaging system. And people who complain of shortness of breath, immediately are red flagged and are triaged for clinical assessment. And of course, as I say, what this means that vital sort of observations can be done by a clinician, and they can determine whether or not the patient falls into sort of low risk, moderate risk, or high risk. If we could move on to the next slide. So what we propose, and I think this has been seen in other nations, is a sort of tier-based triaging system for COVID-19 patients, where you take into consideration risk factors, disease progression, important sort of vital, so the temperature and sort of oxygen saturations and such like. So if you have a young person with COVID-19 in the community who has been seen, has not got a temperature, we can be confident that this person would benefit from staying at home. They don't need much clinical input. And this will be quite a high volume of the population. As we know, 80% of people resolve COVID-19 at home. So they're on the radar, but they don't need to be followed up. Whereas if you get a tier 2, a more sort of medium risk group, so these are people who may have comorbidities, but these are people who aren't shielding, people who are not short of breath, that sort of group, that you keep them on a follow-up scheme. You have perhaps intermittent clinical contact with these patients, and you keep an eye on them until the symptoms resolve, or certainly they're sort of 2 weeks on from onset of COVID-19. And the ones that we deem sort of tier 3 are the high risk ones, the ones that are complaining of shortness of breath, the ones who are red flags, but perhaps not deemed for admission. These people need constant clinical follow-up. They need to be assessed. They need to be monitored at home. And the volume, we know that this isn't a large amount of people, and there needs to be a very low threshold for triaging them to the hospital and for early intervention. Thank you. Next slide. So in summary, I think that what we are saying is it may be that expanding the basic level care is actually more important in the context of the pandemic than expanding sort of ICU care. I mean, what we don't want is it's almost like a defeatist approach. If you're sort of, you have a moderate basic level care, but you're tearing up your ICU, you've made a decision that people are going to be severe and people are going to need this, sort of intervention. However, if we step back and look at those who have actually expanded their basic care quite significantly, so people like Singapore, India, South Korea, and China, who have had a robust sort of basic level primary care, they've done really well. So Singapore, for instance, had 900 public health clinical assessment units, which they put up for people to be clinically assessed and triaged, whether back in the community or in hospitals. You had South Korea, who had a similar sort of triaging system. China, who went from having a 10% case fatality rate to a 1%, who within a few weeks managed to put up 14 hospitals, adopting the same concept of early intervention and early treatment. And I think if we use this notion of a central monitoring system, where all positive confirmed cases are being monitored and followed up, I think this is an effective way of, avoiding sort of severe cases of COVID-19. And I think, echoing what I've said previously about correction of oxygen, about introducing, sort of immunosuppressants and such like early, is very important and has been proven to lower mortality, which is essentially what we all want. Thank you. And I leave you with this because I do think that, you know, quite poignantly, it's the community sort of clinical assessment. The battle for saving lives will be won in the community. And I think that rings true, because I think if we actually ramp up basic care and triage effectively community COVID-19, picking up all the really sick cases, as it were, I think that we are more likely to be less overwhelmed, use less resources, and ponder on with this monstrous that is COVID-19. Thank you very much for listening, and I shall take your questions later on.
Oh, thank you very much, Mansab. So yeah, that was a fabulous presentation. So I think we go back to the continent. We have Dr. Malunga from Malawi with us. So, karibu daktari. Yeah, you be good to share you can share your slides from your end. I hope you can, because the technology has caused a bit of mayhem tonight. So apologies.
Great.
Okay, the floor is yours.
Thanks a lot. I'm Remo Malunga, working as a registrar at Kamuzu Central Hospital, and I would like to share my experience as a frontliner in the fight against COVID. So I'll take you through the background statistics, frontliners' experience, and some of the lessons that we have learned, as well as what we want to do in the future. So Malawi has one of the most strained health systems with low resources and less equipment. It has a 3-tier level system, and it offers free health services to the public. Of note is that we also have private or paying facilities, but mostly people tend to access the public services. The first 3 COVID cases were confirmed on the 2nd of April, and by the 7th of April, 7 cases were registered. Mind you, this was the time whereby we were politically unstable. All sorts of political fracas was happening. Most of the cases were imported, and returnees were the ones that were mostly infected. DNA, PCR, and gene expert were among the diagnostic tools, and we are currently battling the second wave. Internationally, roughly about 120 million cases were reported, but in Malawi, as we're still fighting the second wave, we have a total of 209,096 cases, of which 32,894 positive cases, and we have about 1,088 deaths. So as a frontliner, the first case that we had seen was of MRM, a 52-year-old female, who had presented with shortness of breath and dry cough for about a week. This particular person was on self-isolation at home until after about 5 days when she reported to the hospital. She was also a non-hypertensive patient and also diabetic. We didn't know how. We didn't know if they are compliant to medications. On arrival, her SATs were at 40% on room air, and when we had put her on a cylinder, the SATs went up to 50 liters. The BP was 160/90, and heart rate was 111. Random blood sugars were 513. Her chest had bilateral crepitations. There were normal heart sounds. Our impression was that she had acute respiratory distress syndrome and diabetes. Immediately, we had started her on ceftriaxone, azithromycin, multivitamins, dexamethasone, and heparin. Even though the patient was put on high flow O2, they didn't improve, and death occurred in the next 48 hours. It should be noted that when this patient was coming to the facility was not that prepared to handle a COVID patient. In fact, the isolation center was not that set. There was no PPE, and the health workers were afraid because we are not told what we're going into. As a matter of fact, we were supposed to have guidelines to guide us on on how we should deal with the patient, as well as how we should protect ourselves. Moving on to the second wave, just an overview of another case. We had a HM, 58 years old male, who had presented with coughing, blood sputum, generalized weakness, shortness of breath. He had no history of diabetes or hypertension. He was non-reactive. This patient was seen at a district level. Upon seeing that he is deteriorating, they decided to refer her to the COVID center, which was set at the main hospital. On arrival, he was very hypoxic. He was confused. His SATs were around 30 on room air and had picked up to 77 on a cylinder via mask reservoir. The BPs were normal. They were they were tachycardic, they were febrile, and the GCS was around 14, 15. Of note was that they had reduced air entry, and they had crepitations bilaterally. We did a chest X-ray of which it had shown right-sided pneumo. So our impression then was pneumothorax, acute respiratory distress syndrome. We had done a complete blood count, U's and A's, liver function test. We did also VDRL. We had put a chest drain. We were doing chest physiotherapy, and we had also studied the patient on ceftriaxone, azithromycin, paracetamol, dexamethasone, heparin, and vitamins. Of note was that this patient had stayed with us longer, about 25 days. What I wanted to compare between the first patient and the second patient, the first patient was the first wave. During the first wave, we were not that prepared to handle a COVID patient. But during the second wave, that's when we had put field hospitals, and we're doing triage. Patients were coded. The hospitals were harmonized. Once anyone comes in with coughing, shortness of breath, or any other related symptoms, they were triaged and sent. They were triaged and sent to the COVID centers. Moving on, we were trying also to compare on how virulent the first and second wave was. The second wave was seen to be more virulent, as it had seen that the transmission was at a very fast rate, while the first wave was less virulent, as the transmission was seen at a slow rate. On length of stay in the hospital, during the first wave, patients tend to have stayed in the hospital for a short period of time, about 5 to 10 days or so. But on the second wave, patients tend to stay in the hospital for more than 14 to 30 days. And on the first wave, complications were less and easily manageable, like diabetes and hypertension. But for the second wave, the complications are more difficult. For example, we're looking at increased numbers of lung fibrosis. We are looking at increased numbers of hemorrhagic stroke. We are also looking at increased numbers of people that are oxygen dependent. Once even you discharge them, they have to buy oxygen concentrators to stay on oxygen concentrators in their homes. What are the lessons that we have learned? We have learned that early diagnostic and prompt treatment is vital. Most of the patients tend to seek care late, and in turn, when they are coming to the hospital, they had already deteriorated, and even if we had pushed them through, they were not making it. We also have a centralized approach in case management. Previously, people tend to manage patients in their own ways. We didn't have like proper protocols, but now at least we have protocols that we follow. For all cases that are severe, we push them straight forward to the field hospitals. Whilst for the cases that are mild, we have a rapid response team that tends to follow them up in their homes. COVID is more of a psychological illness. In that context, we also have involved our psychology team for psychotherapy. Most of these patients tend to suffer from psychological illnesses other than the COVID itself. So mostly we involve our patients in counseling sessions, as well as their guardians. Involvement of rehabilitation officers and treatment centers. We also have involved physiotherapists to do chest physiotherapy. What we also have learned is that COVID is not just a chest illness, a lung infection. It's also a mad organ failure illness. So now our approach is different, because previously we just had we just centered much on the lung other than the other organs in the body. So for the future, mostly what we want to do is we shouldn't wait for the symptoms to become worse, but we want to start treating our patients early. We want also to adhere to our treatment protocols. And mostly we had seen that most of our patients tend to die because we were not putting much attention on the comorbidities. We also want to consider other organs when treating COVID. That is why we want it to be a multi-organ approach instead of just focusing on the lungs. Psychotherapy is also included in pre, in, and post-hospital care treatment. Thank you. That was my short presentation.
Okay, thank you very much. Thank you very much, Dr. Malunga. And I guess you're still at work, right?
Yes, I'm at work.
Okay, pole sana. Okay.
I'm currently.
Okay, I think because at work, there's a question here, I think from Dr. Mlawa is asking, were you prepared for the second wave, or it just took you by surprise?
Apparently, we are not prepared for the second wave.
Oh dear. Okay.
We are not prepared. So
okay.
Our holding area at the main hospital would hold up to 15 patients. So previously, when the first wave, when the first wave was kind of subsiding, we kind of being reluctant now. So coming to as we are approaching the festive season, that's when there was that's when the second wave had started from.
Okay, I think the follow-up question was that do you have much support from the government?
Right now, there's much support from the government in terms of production of oxygen cylinders, CPAP machines, as well as monitoring equipment. At least we have support from the government.
That's very good.
Okay, fantastic. I think thank you very much, Dr. Malunga. I have another question here for Dr. Hafiz. Do you use anakinra? Because I don't know what that is, so probably you. And someone is asking, they want to know what is the physiology behind it.
So I thank you for the question, but I don't have any experience with that agent. We haven't had it available in our pharmacopoeia, but I do know it is one of the repurposed antiviral agents. So I can't say much about it because I haven't had the any experience with it. I'm afraid it was never made accessible to us, and it was never on our guidelines. We did have Kaletra, which was an HIV drug combination of lopinavir and ritonavir, and we did use that initially, but then when the studies came out and showed that it wasn't really showing much response, it was promptly dropped out of the guidelines. The only antiviral agent that we currently have, which is an oral agent, is favipiravir, that we're using quite extensively. Yeah, so I'm sorry, but I'm not able to give you much more information about that agent.
I might be able to add about that. If you look at this drug is used in rheumatoid arthritis patients, is an interleukin-1 receptor antagonist. And if you look at the pathophysiology of COVID-19, when Dr. Hafiz talked about the asymptomatic phase, biological phase, then immunological phase, you get the so-called cytokine storm. So if we assume that this drug blocks the interleukin-1, interleukin is one of the cytokines which provokes the last part of immunological response, where makes patients be very unwell. So that's a presumed mechanism of physiology in terms of how it works.
Yeah, but to add to that, I don't think there have been many studies with that particular agent. We know that the interleukin 6 inhibitor, on the other hand, tocilizumab, when combined with corticosteroids, has had much better effects, and therefore we're using that quite a lot with our patients who are hospitalized and with high oxygen requirements, kind of to prevent them from going into ICU admissions.
I think the UK are using, some parts are using a similar sort of regime as well, because I think that is the one that's been shown to be effective. Antivirals in general actually haven't shown sort of to be a necessary intervention, if you like, at the moment, we should say.
I think there's an additional question here. Has any of you guys used ivermectin?
I knew that one was going to pop up. No, heard so much about it, but I'll be very honest that we've not used it, because it's not really clear now whether to use it, at what stage to use it. There are some papers that came out of India, and they tried to use it for post-exposure prophylaxis in healthcare providers. And that's about the only setting that I can think of where it has been studied. I have seen quite a number of reports and videos that have circulated of other physicians having used it, and they say they've had wonderful effects, but I can't say we've had any experience with it here. And that I would add on is colchicine as well, an agent that's used for resistant gout and in rheumatoid arthritis as well. There's some people who've also reported some experience with the use of colchicine, but then again, at what stage do you use that agent? We're not really sure.
Okay, and I think this goes to all of you guys. What do you think is the best strategy or best approach for our African countries when it comes to tackling COVID?
So should I go first then?
Yeah.
Okay. All right. So I think adopting best practices. I think the masks are extremely helpful. Social distancing, that does work quite well. Vaccination, that's the other thing. We've seen, we're now at the tail end of our second wave. And we feel that having adopted the vaccinations early and to a large segment of the population has really helped us in at least putting that surge down. So the usual things that we've talked about, the public health, washing hands, putting your mask on if you're in public areas, having access to the vaccine. I think those are really important strategies that need to be adopted so that we can all fight this thing together.
Absolutely. I mean, I think that it's exactly what you said, really, Dr. Khadija, because I think in the absence of a vaccine, because we all know that there's a sort of vaccine inequality, and obviously the richer nations have done pretty well in vaccinating or trying to vaccinate their nations. And I think WHO is doing really well trying to get vaccines to low-income countries. So that hopefully will be coming, and we can sort of use that as an interruption for viral transmission. However, I think if we look in the beginning, African countries as well as European countries were on equal footing, because actually if people adopted good public health measures properly, they can do, as we've seen, very well. So I think, people thinking we've not been offered or we don't have access to vaccine and seeing that as a barrier to containing COVID-19 would not be the right approach. I think the right approach would be to make these public measures sort of the norm at the moment. As we all know, same things that are having the masks, the hand hygiene, governments getting involved, I think, and letting their, populations be aware of COVID, I think, and not sort of shying away from it and encouraging good practice themselves so they can be seen to take precautions. I think these are things that really make a big difference and things that need to be adopted. And of course, basic care, I think if, they trying, because basic care actually is already a challenge in some parts, but concentrating on sort of seeing people before they need a lot of intervention in low income countries, I think would be very important as well.
Okay, thanks very much.
Yes,
I think
yes.
the main thing is just if we don't have the vaccine, we have to do the simple things and we do them well. I think we should be fine. I think the message have to come from the top, if you like. So the public health message have to be very clear. So thanks very much for that. Dr. Gideon, do you have anything to add on there?
Dr. Nasibu, apologies.
Yes.
Umeruka, there's two doctors who've asked questions. You've not asked them. Dr. Mlewa and Dr. Malunga on the chat.
Yes.
Dr. Mlewa's question they just answered. This is the one we're answering now.
And Dr. Malunga?
Dr. Malunga, that is coming next.
Okay.
And there was one more question from the beginning. I think the first question was asked by someone who said, what is your experience about in patients with HIV taking antiretroviral medications? Are they at risk or are they protected?
So that's quite an interesting question. So for the patients with HIV disease, I'm not the one who manages them. We have an infectious disease unit that takes care of that. Having said that, the HIV, we don't have a very enormous HIV problem here in the United Arab Emirates. So I cannot make any comments on HIV medicine because I'm completely divorced from HIV medicine. But if you look at the list of sort of the vulnerable populations, we know that patients who are immunocompromised as a result of using immunosuppressive therapies or they have malignant conditions, they are more prone to get a more severe infection. So I would say that perhaps those that are on the treatments and they're well controlled and their HIV viral loads are low, probably don't have a higher risk of getting the infection. And if they adopt all these sort of preventive measures that everybody else does, they should be okay. But whether the agents that they're taking put them at particular risk, I don't think I have enough expertise to give you an answer on that.
Thank you. I think that is well answered question in terms of any chronic condition. You have to try and manage it very well. It has to be controlled. If it's not controlled, once you get COVID or any other infection, that condition becomes worse. I think that's a message to take home.
Okay. I think you will have another question for Dr. Malunga. Are you still on?
Yes, I'm on.
Yeah, there's a question here for you. Are you managing to deliver the same level of care to the patients who happen to live in remote part of the country?
Yes. That's why we have a rapid response team that goes around. If they notice that the patient are deteriorating, they will move them as fast as possible to the field hospitals. Of course, we have a problem with the masses. Not each and everyone is accepting that COVID is there. There's still some resistance, but we are trying our best.
Okay. Thank you very much. Did I miss another question there? Okay. I think this goes to Dr. Hafid, I think. How are the public compliance to public health measures in the United Arab Emirates, especially handshaking being a cultural norm?
I like that. It's not just handshaking, we do a lot of hugging as well. And the public health messages have been well adopted. We all now elbow instead of shaking hands. So yeah, it was very challenging in the beginning, but as the messages were on the radios, they were on television, they were always there as big, huge placards in the hospitals as well. And therefore people have kind of gotten used to them now, and we're not finding it so strange. But yes, in the beginning it was quite challenging.
Okay, thank you very much for that. I think Emma Kawa is asking Dr. Fatma, what vaccine do you use in Gibraltar? Or vaccine?
Oh, yeah, we actually, so far, we've only used the Pfizer and BioNTech one. So the entire population has been offered that vaccine for first and second dose.
Okay. Thank you very much. I think I cannot see any more questions from my end. Gideon, can you see anything there?
I'm not able to identify any questions apart from saying that the presentation has been very well delivered, and we are grateful to the presenters, and it has been a privilege to hear from all of you.
Okay, and I think before we end up our day, I think I will let our presenters have the final word. So starting Dr. Hafid, our final word, please.
Right, so I'm new to THEDA, and I'd like to thank the organizers once again for accepting me in their circle and for giving me this opportunity today to get in touch with the larger community. So I know there's people listening from Tanzanians, listening from all over the world. We need to come together and help our nation. I think those simple public health messages that have worked in other countries, we've seen the examples of Singapore, we've seen the example of South Korea, Japan, Gibraltar, to some extent in the United Arab Emirates as well. I think that there's simple messages which really can work, and we need to try and get that across for our fellow Tanzanians to take them on board and prevent unnecessary deaths.
Yes, thank you very much. Dada Fatuma.
Yeah, no, I think I echo what Dr. Khadija has said. Really, I think COVID-19 is a global problem that can have a global solution. And I think, low-income countries, I think a country like Tanzania can have a handle on it. And I think that to use these sort of simple, low-cost, basic care sort of measures, public health measures, washing your hands, having your mask on, keeping your distance, not shaking hands, no hugs, that sort of thing, that seems doable across sort of age groups and such like. But I think an understanding of what implication that can have is very important. So I do think that the message from, people from the government to let their community know how effective these measures can be is important.
Thank you. Thank you very much. Dr. Malunga, final word, please.
I'm agreeing with what my two presenters have alluded to. It's just, we can fight this. We can fight this. Mm-hmm. Let's mask up. Let's sanitize. Let's have social distance. Thank you.
Okay. Thank you very much. I think with those great presentations, and it's amazing having you guys on board today. And I think this is going to be a great, I think, beginning of great things to happen. I think we should do this more often. We should share learning and experiences together. And I think collaboration, they say, is the fuel of the future. So let's work together and stick together and keep protecting one another. and we can get through this. So on that note, I think I will end up our meeting from now. So thank you everyone for attending, and this presentation will still be showing on our YouTube channel, so you can go back, you can watch it again when it's all processed. So thanks very much and have a good Sunday.
Thank you.
Thank you, and
Bye.
bye everyone. It was lovely.
Thank you.